Okay, welcome everybody to the Health and Wellbeing Board. I'll just go through a bit of housekeeping if I may. This is an in-person meeting. It is a committee of the council, so it is being recorded and live streamed on the council website. We will continue to use the flag system for those who are not aware of it. When people are giving presentations, just give you kind of a 2-minute warning that that's coming to, your 2 minutes has come 2 minutes prior to the end of your presentation time. Right, please sit in your allocated seats because otherwise it really messes up the live stream in terms of knowing who you are. And I just ask that you make sure that you turn your mic on and off when you're speaking, okay? There's no planned fire alarms today, so if the alarms go off, the members and guests will be escorted out of the building by officers. Okay, so if I take it you all know each other. Do you all know each other? Yes? No? The names are on there, okay. All right, so if I just move on to apologies then. So I've got apologies from Claire Demel, Gloria and Sheila Murphy. Have I got any other apologies? Right, thank you. Right, so if I then just move on to April's meeting, notes of the meeting, which you'll find on, is it on page 5? There are no actions from the last meeting, so do members that attended the meeting in April agree that the meeting is a true reflection? That's been agreed. It's a shame we're in here today because I actually felt when we were in the committee room, we actually had a far better conversation and the committee situation just helps people be a bit more open. This is far too formal, I tend to find, but I am reliably informed that we have the committee rooms booked for the rest of the meetings. So that's good news. Okay. Do you have any declarations of interest?
Sorry, Chair, just one thing on the, for today's meeting, on the membership, just 2 things. I just update that I'm now permanent, not interim, and also more importantly, Rita Thakaria, who was our partnership director, joint appointment with the council, Putton Nelft, has left her post. She's gone to another position in Westminster, Kensington, Chelsea, and we are looking. I'm talking with colleagues from Nelft and Eput at the moment, and we're potentially looking to recruit that post probably sometime mid-July.
Sorry, Chair. Fiona Ryan is not working at Basildon Hospital anymore. She's at Southend. It's now Cherry West in terms of the membership.
Thank you, Margaret. Take it there's no declarations of interest after all that. Okay, great. Okay, so if I move on to agenda 5, which is the JSNA review. So there's a covering report on page 13 of today's papers. There's a 20-minute presentation and 10 minutes for questions. Sharon will present this item. So if I just hand over to you, Sharon.
Yes, thank you, Chair. Unfortunately, we've not been able to get the technology to work this afternoon to get the presentation up on the screen. But you were sent a copy of the presentation in the report pack for today, and it is available on the council website with the papers for today. So if you can refer to that presentation, please, as I go through it. And apologies that we've not been able to get it on screen. So The purpose of the discussion this afternoon is to briefly take you through a review of the JSNA, the Joint Strategic Needs Assessment in Thurrock. And the review looked at all of the JSNAs that we've produced in Thurrock since 2017, so quite a thorough review. I must record my thanks to Louise, who is one of the public health practitioners in the team who did this work for us. So I'd like to record my thanks to Louise for doing this. As well as reviewing the Thurrock JSNAs, Louise also looked at JSNAs produced in some other areas as well to do a comparison and try and identify areas of good practice. The review sought to identify the strengths of the Thurrock JSNA process, but also to try and identify areas for improvement. And then there are some proposed recommendations for the board to consider at the meeting this afternoon. So, just a little bit of background then of Joint Strategic Needs Assessments, or JSNA as we all say. So the duty to undertake a JSNA is set out in section 116 of the Local Government and Public Health Involvement in Health Act 2007. So it's a statutory a need for every local authority to produce a JSNA. And then under the Health and Social Care Act 2012, the NHS commissioners started off as being primary care trusts, then clinical commissioning groups, now the Integrated Care Board. So NHS commissioners, local authorities, and the Director of Public Health, as part of their statutory role, have a duty to produce a JSNA, and that duty is discharged via health and wellbeing boards. So those of you that have been around for a little while will know and remember that the first JSNAs that were produced were quite massive documents. They could be hundreds of pages long. They were very technical documents and certainly not very accessible to the majority of people. And I suspect the only people that ever read them were public health and researchers. I'm not sure that anyone else ever paid that much attention to them. They were highly technical documents. But over the years, JSNAs have evolved. There is no statutory guidance as such as to what a JSNA should look like. And so over the years, they've changed, and different local authorities, different health and wellbeing boards have developed different approaches. But a good JSNA should be available online. It should be a digital copy. It should also be possible to pull off PDF summary documents. But JSNAs should be useful documents. They should have a practical application as well. And they should be user-friendly, so that they can be used as a tool to be able to help people understand the health and wellbeing needs of a particular population and be used to support commissioning as well. But there are 4 things that good JSNAs also should have. They're there to assess the health and wellbeing of a local population, but they should also look at the future needs of the population. So a good JSNA would also be using data and intelligence to forecast the needs of and the needs for the health and social care of local people as well. It should be used to inform service development and commissioning. So a JSNA shouldn't just be produced to tick a box and to say that we have one. It needs to be a useful tool and it should be used to inform commissioning, as I've said, but not just for commissioners, for providers as well, to be able to help them to understand what the needs of the population and future needs might be. JSNAs can be organised in different ways, but normally they would cover the different domains of public health. So the domains of public health we tend to describe as health improvement, health protection, health and social care, and the wider determinants. So the things that impact on the health of a population, such as housing, jobs, transport, etc. And again, good JSNAs, a feature of a good JSNA is that they would be local designed, but there would be local ownership. So the documents may be produced largely by the local public health team, but they should be collectively owned. So the guidance also says that the Health and Wellbeing Board, so the local Health and Wellbeing Board, should have oversight of the JSNA. They should have oversight of the process. They should ensure that any recommendations that might be in the JSNA are delegated to the right people, that any recommendations are actually actioned, and the Health and Wellbeing Board should have ongoing oversight of those processes. And the Health and Wellbeing Board should also be responsible for ensuring that the priorities that are identified in the JSNA are relevant ones. So there should be priorities that have been identified in the Health and Wellbeing Strategy, for example, but other priorities that might be identified by the Integrated Care Board and the Council Corporate Plan and other plans. So they shouldn't stand in isolation. So the review then that Louise undertook for us of Thurrock JSNAs, so Thurrock, all of Thurrock's JSNAs are produced on the Council's website, and they're produced as PDF documents, so you can look at them online and you can pull them off and read them as well. And so there have been a whole series of JSNAs done, and a feature, I think, in Thurrock is there's been tended to be updates. So, for example, a JSNA was done looking at special educational needs and disabilities back in 2018, and that was refreshed last year. Similarly, there was a sexual health JSNA done in 2020, and that was updated last year. So that tends to have been a pattern that the JSNA in Thurrock has taken previously, which as a board we might want to reflect on that and think about whether that's a pattern that we want to follow in the future, or whether we want to use a different approach to that. So looking at the highlights then of that review. So the JSNA in Thurrock covers a wide variety of topics. All of the JSNAs, or most of them, include a good assessment of vulnerable groups in Thurrock. There is evidence of input into the JSNA from other stakeholders, and to a varying degree, some more than others, there is also some evidence of user experience where the JSNAs have tried to capture the views of service users. And there's also evidence, again, to a varying degree, of how different professional groups have been engaged as well. The JSNA structures are usually quite well laid out, with a key point section and recommendations etc. And where large JSNAs have been produced, usually there is a short summary for people to be able to access rather than read the whole, the whole report, because some of them are very large. So quite a lot of positive things there. When we then compare Thurrock's JSNA with some other local authority areas and look at what they do, some local authorities align the JSNAs to different directorates across the council. Some use a life course approach to organise their JSNA, so rather than using the domains of public health, they'll use a life course approach. So their JSNA would be developed and published, focused on key age groups. So starting well, for example, for looking at maternity and children and young people services, living well, thinking about adults, and then aging well for older people. And instead of splitting things off to health protection or wider determinants or whatever it might be, you look holistically at the needs of that population based around the stage of their life course. So some local authorities use that approach. In Thurrock, our JSNA is hosted on the council website, but some local authorities have developed what we call microsites. So there'll be a dedicated health and wellbeing board or JSNA pages that so you link to them from the council website, but there's a separate website that hosts some of the JSNAs that can sometimes allow for more digital access and functionality, etc. So that's something that as a health and wellbeing board we might want to look at as well. Some councils really treat their JSNA as just a data exercise. So it's just like a public health observatory, if you like, of data, rather than having any story book involved or any narrative at all. I wouldn't recommend that we do that in Thurrock, but some local authorities have taken that approach. And then increasingly, some local authorities will have a strong focus on health inequalities. So they'll link their JSNA to the NHS Core 20 +5 health inequalities priorities, very much focusing on the inequalities in local populations. So when you look comparing Thurrock with other areas, we are good in some things, I think, but there are also opportunities to learn from the good practice of other areas. So based on that, the proposals that are put forward then for you to consider as a board this afternoon. So this is the principal slide, if you're following it in your papers, is that our JSNAs going forward, rather than have a programme, a forward plan, which is about refreshing and updating JSNAs in the past, done in the past, that instead of having that approach, our forward plan for the JSNAs should be informed by our health and care priorities, really, our council corporate plan, what our priorities are for commissioned services, but also where a new priority might emerge or new data or information might emerge. There might be a national policy agenda, for example, and we'll decide locally that we don't currently have sufficient knowledge or understanding of the needs of the people of Thurrock around that particular issue. And so the Health and Wellbeing Board or another partner might commission a JSNA They might say, well, I don't know, looking at Mark, thinking something like gambling harms, for example, we might decide that we really don't have enough information, just using that as an example. And so we might say what we would like is a JSNA around that issue. Or it might be something to do with children or any other topic that we would decide we wanted to do a deep dive and do a JSNA into that particular issue. But that we should have a forward plan for our JSNAs that grows out of a collective understanding of what our local priorities are for Thurrock. User lived experience needs to be a given, and it should be a golden thread running through every JSNA that we do. And we need to be prioritising that. So we're actually capturing the voices of our local people. We've got small examples of that, I think, that Healthwatch have done, for example, Kim, and the voluntary sector has done. But there's more that we need to do to make sure that the voices of local people are properly included in any work that we do, but also that we're engaging with other stakeholders, professional groups, etc. So one of the proposals is that, having looked at the way some other local authorities organise their JSNA, there is a proposal that going forward we organise the Thurrock JSNA around the life course. So that we would, if we decide to go down this route, we would reorganise the JSNA, we would reorganise the web pages, etc., and that we would focus on that life course. So thinking about starting well, living well, ageing well. Some JSNAs also include dying well. So that, again, is something for the Health and Wellbeing Board to consider. And then rather than wider determinants being a separate issue, you actually look at a holistic approach. And so where things like education, housing, transport impact on the health and well-being of our population, that is actually weaved into the process rather than it being considered as something entirely separate. So coming on to, so in the report they're called recommendations, but proposals really for us as a board to consider. So one I've already mentioned that JSNAs should be linked to strategies and priorities that we've already identified, a recommendation that we adopt a life course approach. The other suggestions here, proposals here, is that as well as developing a summary JSNA, so what is really helpful, we don't currently do this in Thurrock, but one of the things that I think is really useful is that there is a summary document. So if you're someone working in children's services, for example, and you want to have an at-a-glance view of what the health and needs are of children and young people living in Thurrock, you can click onto the Starting Well section in the JSNA, and what you get is a highlight summary report that gives you an at-a-glance overview of the health needs, and the same with living well, aging well. But that we also do what we call JSNA deep dives. So it might be, I mean, I used the example of gambling harms earlier. If I use that one again, so that would fall probably under living well section of the JSNA, but as well as that overview, we'd have deep dive, much more detailed reports that will allow people to go in and look at that if they want to have more detailed information, for example. And I think the other is that we should, in fact, include the Core 20+5 priorities because that drives a lot of the work that we do across the health and social care interface, that JSNA recommendations should have short and long-term recommendations. All recommendations need to make it clear who is responsible, either an individual or a group, another board perhaps, that is going to be responsible for that recommendation. And it's not in the pack, but I've added here that the forward plan and the timetable for JSNA should come to the Health and Wellbeing Board for approval, and JSNA should also come to the Health and Wellbeing Board to be signed off before they're published, so that the Health and Wellbeing Board has a really important governance role to ensure that the JSNAs that we produce actually do follow the principles, if we agree those principles at the board this afternoon. But that the Health and Wellbeing Board then also takes responsibility for oversight of delivery of any recommendations that are in that JSNA as well. So very much kind of tightens up the governance of the JSNA process. So I'll stop there, Chair, but obviously very, very happy to take any questions and hopefully gather some views from the board as to whether the proposals that have been set out seem sensible, whether the board is happy to endorse those, or any other thoughts that people have as to how we can improve the JSNA going forward. Thank you.
Okay, any questions? I'll probably go to Rob first, and then I'll come to Mike.
Thank you, Chair. So if just before we go to question, I've just add a couple of bits. So can I just say thank you to Sharon for the presentation. Just a couple of observations, being relatively new here. This is really important. So this is going to be the framework which will empower us to undertake in a co-produced way the detailed data, which then informs strategies, which then should inform actions which improve the health and well-being of the population of Thurrock. And so, you know, just to add a couple of quick comments just to what Sharon has said. Some of it, I would suggest we need to look at a long list of subjects, but then on the basis these will be co-produced but led within the public health team, there are capacity issues for how many we can do in any 1 year. So if we could look at preparing a long list, then bringing that back to the Health Wellbeing Board for you to determine which you think are the priorities on the basis of maybe two or three a year max, then we can kind of program it over a period of time and using proper data to justify those decisions. Some of it, as Sharon said, some of it could be life course led, some of it could be subject led. Some of them could be a hybrid of the two. So, you know, just an idea, COPD, you know, chronic obstructive pulmonary disease and chest infections could be linked to something around air quality, could be linked to life course. So you cover different pieces. So that could be a topic which you may be interested in. Also, when I came here 9 months ago, so the work program for last year had a mental health commissioning plan or strategy. It was used different terminology in different documents. We didn't act on that last year, but we have been in discussions with, there is a Southend, Essex and Thurrock mental health strategy which was undertaken a couple of years ago. We've been in conversation with the ICB recently about the potential to look in that space through the lens of the ICBs being reorganised and local reorganisation, as to whether that would be an interesting space to do some work. And again, if you look back at 2018 when we last did the work here, it was done as a children and young people mental health strategy and then an adults one. We could take a life course to that actually, because one of the issues which really came out post-COVID was that 13 to 25 age group, which straddles the two. And so that might be an interesting area for you. And so I just want to kind of just throw in there that this is really quite important. And I think we'd really welcome a long list that which we could then bring back to you and ask you to prioritise the work going forward. Thank you.
Thank you, Rob. Margaret.
Thank you. Sharon, I think it's a really well done piece of work, this. I think it's really clear. It doesn't pull its punches. It says where Thurrock is doing really well and where actually Thurrock may want to develop something a little bit more. I was also going to ask about how to prioritise, so I think Rob's answered that. I really just wanted to make a comment, actually, which is the approach that you've described and the different options and the mix of those options actually would really work very well with the recent developments around integrated locality teams and how neighbourhood health is delivered in the community. I think it absolutely sits under that like a foundation stone. And I think clearly the new health and wellbeing strategy would be informed and driven by those JSNA findings and the data that would be captured there. Thank you.
Councillor Rigby.
Thank you, Sharon. There's an awful long list of JSNAs, and you describe quite a long list and talking about bringing long lists. Are you going to look at trying to reduce that number so you don't get what happened before with a lot of reports, but a lot of also overlaps? Is that how are you going to do that if that is the plan?
So, again, different local authorities develop different processes for this. So there's one local authority I'm aware of that has established a JSNA steering group. So Public Health hosts that and lead it, but the steering group is actually involves quite wide membership, including a lay member on that. So, which is somebody who was appointed with the help of our voluntary sector. Actually, it was someone who came forward through a process that the voluntary sector led and was appointed, if you like, to the JSNA steering group. The process this local authority then uses is they have what they call an application process. So if somebody wants to request a JSNA, there's a short form for them to complete. That goes to the JSNA steering group. The steering group then discusses that. They make a decision whether actually a JSNA is needed. It might be that there's already a great deal of published evidence and already a lot of data available on a particular topic. And so all that is required is might be the Public Health Intelligence team to pull that together into a summary document that can then be shared, but we don't need to do a JSNA. For other things, it's decided, yes, there needs to be a JSNA. The steering group then consults with the relevant people and determines whether that is a short JSNA, a rapid JSNA, where it's just a case of analysing published data. That might take 6 weeks to do, or whether in fact there is a need for a full JSNA, which can take 6 months if you're going to do a JSNA really, really well, making sure that you capture the voices of local people. The JSNA steering group reports to the Health and Wellbeing Board. So the steering group would then submit a report to the Health and Wellbeing Board to say, these are the requests that we've had, this is our assessment, this is our shortlist of JSNAs that we think are a priority for us to do this year, and these are on that long list. So it's a very similar process to the one that Rob just described, but it would be extremely difficult for us to do that as a Health and Wellbeing Board. So I mean, it wasn't in the list of recommendations, but now that I'm thinking about it, we may as a board want to make a recommendation that we establish a JSNA steering group. That would be chaired by either the Director of Public Health or a consultant in Public Health. So Public Health would continue to provide that leadership as Rob has described. But the JSNO steering group will have broad membership, and it would be interesting to hear people's views, particularly, Mark, your views on whether having a lay people on that JSNO steering group as well. And then what we're doing as a board is delegating that responsibility to come up with that list, doing that initial analysis of it, making recommendations to the board, and then we would agree what the list of recommendations would be. But we would be receiving the informed recommendations from the JSNO steering group as to the ones that we should be focusing on.
Kim?
Thank you, Chair. Not a question. Obviously, I think this is very much needed because for many years we've been very involved in trying to get people's voices represented in the JSNAs, and we have been quite successful in some of them, but not in all of them, and some of them have been around way before our time, really. But I was just going to say that list is going to be very, very long, and we've just done, well, we've completed the piece of work around the NHS 10-year plan, which very much showed where there were gaps, what people's priority were, the very people that these are written for. And that piece of work is finished. And that is quite a big document that gives lots of feedback. We're also going out to do the same thing, replicating that around social care and other issues around children's as well, which hopefully will bring back the same sort of intelligence of the voices. So maybe that can be gathered to help to influence which is a priority, as well as just the numbers and what we obviously know is a gap, because we have that already and it's current and it's this year's. So that would be sort of an ask. And also, I know we've touched on it, but really, really, we need dying well added onto the end of that list of living well, because obviously we know there's lots of breakdowns and issues going on within communities at the moment. And if that's on there, it will be a big part that will be done properly and identifying where the gaps are around that for people. So, thank you.
Mark?
I felt sure that Kim was going to pick up on this point, but she didn't. It was just a question around, I really welcome the report, and it was a very clear presentation. I just wondered whether there was a reason why the language on the user lived experience should be a vital component. And then you've got the next point where it says will be framed. So there seems to be a kind of caveat to the user experience that doesn't feel like it's totally congruent to it being a vital golden thread. So that was one point. And the second point was, I think the community and voluntary sector are really hungry for information, for kind of quantitative information. I know we've held one workshop with public sector colleagues around how JSNA information can be better disseminated to the sector and to the public, and I'm really keen that we kind of explore that a little bit further. I think we've kind of started a journey, but actually I think there's more we can do, and I think there's an opportunity for that kind of reciprocal relationship where the sector have so many stories, so much narrative, so much qualitative information. I think we're still missing a trick around how we're joining up those kind of like stories with the kind of quantitative information. So I wonder whether there is part of the recommendations we could do to kind of really think about how we kind of disseminate information and kind of join up the information we have.
So the difference in emphasis with the words is, Louise wrote the words, I've delivered them, so I was kind of able to put a slightly different slant and weight to it. So that's the only reason there is that difference. But I suppose for me, we will. So it's will, not should, if that helps clarify that. Is a really good point that you raised, Mark, about, and Margaret touched on this a little bit as well, around how we can start to work differently with our neighbourhoods. And how can we kind of translate a lot of the rhetoric that we all talk about into language that people living in our neighbourhoods can understand and relate to. The JSNA, as it's said, and this is not unique to Thurrock, this is true in other areas as well, they're really written for a professional audience and not necessarily for for elected members or for all of our stakeholders and for local people. So for me, there's little point in doing a JSNA unless it is going to be meaningful for local people who should be able to understand it. We may need the technical documents. We might still need the technical documents, but we need those very accessible documents that need to be presented in a different way. I'm aware of at least one local authority that organises a JSNA roadshow. So they, and this is something that the steering group, their JSNA steering group organises. I used to work in this local authority, which is why I know how it all works there. So they have a JSNA roadshow, and what they do is they actually will hold events in different communities across the patch, and they will invite people along, and they will share the local data with them. And I'm aware of, one local authority, also use that process and a very simple prioritisation process with that community. It's actually a particular council estate. So they presented the intelligence data to this community. They then had a process of prioritisation using different coloured counters. So the members of the community that were there voted based on their own lived experience and the presentation and the data that had been shared with them, what they felt the priorities were for their particular estate. And it was, I think some people were quite sceptical of what would come out of that exercise, but it was absolutely fantastic. And the insights and understanding that those community members had of their community, they understood the barriers to services, they were coming up with very practical solutions, some of which didn't actually cost anything, about how things could be improved for their community. So I certainly would suggest that that is something that the Health and Wellbeing Board might also want to consider. And that might be a recommendation from the board that you would like us to take forward.
Right. Is there any other comments? I'd like to move it on. Are we suggesting as a board we should have a steering group? Yes? Okay. So I'll add that to the recommendations. So the recommendation is a steering group is set up to, what we're going to do, develop and monitor the JSN, yes, and help prioritise. I really like the idea they get out in the communities and talk to their local communities. One of the things I really wanted to actually happen is have a ward one where we could go to the ward councillors and actually talk about the challenges in those particular wards and actually try and involve the people more about how they can resolve it. And normally the communities do it far better than councils, don't they? Okay. Right, so if it's okay, if I move to the recommendations. Right. So it is recommended that board members note the findings of the review of the JSNA. Agree the principles set out in paragraph 3.2 that will guide the development of the future JNSAs. Agree the framing of the JSAs using the life course approach, starting with growing well, living well, aging well, and I'm adding dying well. So discuss any immediate priorities of the JSNA for the coming year. Well, I think what I want to do is actually set up a group, a steering group, that will look at the priorities of the JSS, monitor the JSS, and work with local communities on the JSS and feedback to the Health and Wellbeing Board. Is that agreed? Sorry.
Just to add one further recommendation, I think that we bring a report to the next meeting of the Health and Wellbeing Board with the terms of reference for the unproposed membership of the JSNA steering group. I'll catch up with Mark and Kim about lay membership of that outside of the meeting, so that's an action that I'll take. But I think it would be really helpful to have that long list, as we described, and an outline plan and timetable to come to the September meeting of the Health and Wellbeing Board, so that we don't lose any momentum with this. We can actually start to get the ball rolling.
So we're asking members to contact you with the priorities?
People can do, yeah, if you, any thoughts that people have got.
I'm not quite sure we've got time to do it justice today. Yes. Is that agreed? I'll send you a long list. If I move on before I get told off, I'm going to tell myself off because I did say there would be, I forgot Agenda 13, which is urgent items of business. Though I do not have any urgent items of business, I did want to have the opportunity to have a statement from the ICB, bearing in mind they're under some significant changes and some cuts. So if I could invite Margaret just to give us a statement on that, please.
Thank you, Chair. I can give you some updated information on currently what's happening. Geographically, there is a preferred arrangement across east of England. Bear with me, there's a lot of names coming up. So the preferred arrangements for the geographical footprint for the 3 new larger ICBs will be Norfolk and Suffolk, Essex, Thurrock and Southend-on-Sea, but that will include North East Essex and West Essex. So it's the whole of Essex footprint plus Thurrock and Southend. And then Bedford, Central Bedfordshire, Luton, Milton Keynes, Hertfordshire, Cambridgeshire and Peterborough as one. What that actually does is it meets with central government's principles of the size of populations that the new ICBs should be responsible for. And central government has said that they would prefer population sizes of between 2 and 3 million. So Norfolk and Suffolk are 1.9 million once they are drawn together. The larger group on the western side of the east of England would be slightly over 3 million, and Greater Essex, as we are thinking of it in line with the devolution for the new Mayor of Greater Essex, would again be slightly, just very slightly under 2 million. So we would increase from the current 1.2 million population for Mid and South Essex and actually make it very nearly 2 million. And actually with the anticipated population growth in Thurrock, just in Thurrock alone, we would definitely be over 2 million in the next couple of years. So it feels like a better balance. There have been some meetings held during May between the chairs and the non-exec members of the ICSs that manage the ICBs in terms of establishing a transition committee and setting out a model blueprint. That's not a structure at this point. It's a set of principles. And it's basically setting out how new ICBs will meet the maximum per capita cost per annum that's been set by central government, which is £18.76. Now, in Mid and South Essex, we have been spending approximately £24 per capita across the population within that footprint. So there are some savings, as you'd expect, to be made. It will require reorganisation. It will sadly and inevitably mean headcount reduction across the ICBs as well. Having said that, I think it will bring some new opportunities, and the way that we work with all our system partners, and particularly with our local upper tier councils, actually, you know, working in a much more integrated and a much more joint way that we have been doing for the last number of years. But I think it will cement that in many ways. I've got a timeline. It's a high-level timeline, but I can tell you that at the end of May, all the ICBs were required to submit their plans, this model of how they would meet the £18.76 maximum per capita. That amount of money, by the way, is for every ICB in England. So it's not just for East of England. That's the limit that central government has set. Some design work across the ICBs in East of England is taking place this month. Something else that is due to happen this month is that the chairs and the chief execs of the new ICBs are supposed to be appointed by the end of this month. We anticipate that July will mean that once the chairs and chief execs have been appointed, that the executive level will then be appointed too. That is still being worked through. There's nothing detailed on that as yet. The NHS 10-year plan is due for publication in July, and we anticipate that the new structures that reflect the shift in functions, and we're not clear on which functions will come into ICBs and which will go out, will actually be really housed within the NHS, the new guidance, the new 10-year plan. So in a way, there's a little bit of waiting at the moment just to see what the detail is in the NHS 10-year plan. We have the NHS planning guidance that came out a little while ago, and that focuses very much on neighbourhood health and a lot of the things that Sharon touched on in her presentation. The implementation of the new structures and the new functions is due to take place between October and December of this year. But we actually anticipate that it won't all be in place and signed off and actually embedded and settled until April of next year. So the process is likely to start in full swing between October and December, but it will, in many instances, it will take us up until the end of this financial year to actually get everything set in place and approved. That's probably the best I can give you.
Thank you. Are there any questions? I'm just aware of the time, though, so I'll just give a minute or two. No? Okay. Thank you for that, Margaret. Really grateful. But you don't get off scot-free. You've got item 6, report on Better Care Together Thurrock Implication Plan 2022 to 26. A covering report is on page 25. There's 20 minutes for the presentation, Margaret, and 10 minutes for questions.
Thank you, Chair. It says that this is my report. It's a lie. It's not my report. It's the report of a whole host of colleagues, both within the council and within the ICB. And the reason for that is that the Better Care Together Thurrock strategy was written in a collective way with lots and lots of partners, system partners within Thurrock. It's being overseen and the governance sits with TICA, the Thurrock Integrated Care Alliance, which is also the formally adopted alliance committee within the ICB. So it has that governance, it has that formal governance role. And it's been delivered by all partners. Clearly, this was the second iteration of a strategy that Ian Wake, the previous exec director, delivered for Thurrock, and it's clearly set out to advise local residents. Again, I think we have a bit of an issue with it in its current format, in the same way that Sharon referred to JSNA documents tend to be written for professionals. Well, the BCTT implementation plan was again written for professionals who were expected to deliver the elements that are contained within it. And I'm not certain how well we've publicised this for local residents over the 4 years. We've acted on it, we've delivered, and hopefully we've seen changes and improvements in outcomes for people and improved health and well-being. But I think going forward, and I know that we want to link the next iteration of the BCTT plan very much alongside the new health and wellbeing strategy. We need to merge them as best as we can. And I think publicising it much more to the public and actually having the public much more engaged in a very hands-on way with the next iteration, I think will actually serve us all really well. I won't necessarily go through all the detail in this report, but what I would like to do is just pull out a few highlights from the different chapters. There are 10 chapters in the Better Care Together Thurrock strategy. I want to focus on several of them, not all of them. Some of them are more technical, I think would be the right word, rather than deliverables. Chapter 4 is about community engagement and empowerment. And what I'd like to just mention is we've got communities of practice that have been created and a framework has been developed around that. And we've now really, over the last 3-4 years, we've now been really trying to get a really much better understanding of what local communities' priorities are. Rather than, so it may be a ward, it may be a locality, it may be a neighbourhood, it may be a PCN area. But we really need to understand what are the priorities for those local people, what is it that's affecting them most of all, and what is it that they really need our help to change and to improve. And I just would like to just reflect what Councillor Hooper said about engaging ward councillors on the priorities in terms of the JSNA. It's written here as well, actually engaging with ward councillors on priorities, ward councillors as their local representative of the local communities. The CVS Stronger Together Charter is being agreed by all partners, and the ICB, along with the council and everyone else that works in partnership in Thurrock, is very much part of that and very much wants to see that deliver for local people. And I was really quite taken aback. I didn't realise the number. We've got more than 150 micro enterprises in Thurrock, and they are driving quite a degree of community economic development. And I think it's absolutely, I'm staggered by that. I think that's absolutely marvellous. I think it's really impressive to say that we've now got more than 150 micro enterprises in Thurrock. I think that shows the innovation and the entrepreneurship of people that live in this borough. Chapter 5, Transforming Primary Care. This may be something that members of the public have seen a little bit more of in their day-to-day dealings with their GP practice or their local clinic or whichever part of primary care they've come into contact with. So we have R's roles. Please don't ask me what the acronym stands for because I never get it right. However, the R's roles are aimed at primary care. They are social prescribers, they are care coordinators, they are additional paramedics, they are additional nurses, they are first contact physiotherapists, they are all sorts of different disciplines and professions. More recently, and it isn't stated in here because this is a 24-25 end of year report, But since the beginning of, before the end of the 24-25 financial year, but much more in this financial year, central government has released additional fundings for new GPs under the R's programme as well. So we've now got some more GPs in Thurrock that are actually being funded directly through NHSE under that programme, as well as other GPs that we've managed to recruit. The R's roles and the primary care networks are really central to the integrated locality teams. That doesn't mean that they manage and control the integrated locality teams, but they are very much a big part of that. And the work that we're doing with our PCNs, and unfortunately our integrated locality teams in Thurrock are coterminous with the PCN geographical areas as well, so it makes life a lot easier. And what we've discovered is that the innovation that the PCN staff, including GPs and other clinicians, along with all our other partners in those integrated locality teams, the innovation that they are driving is absolutely remarkable. I'm quite happy to give you a little bit more detail on what the ILTs are doing, if you wish. But in terms of transforming primary care, this was really about getting more GPs into Thurrock, because Thurrock was the most under-doctored area in England. Not only do we have 4 GPs through the National GP Fellowship Programme, the funding for that has now ceased, but we still have those 4 GPs in Thurrock. We also have 1 PCN and 7 GP practices who are now training practices, and they are recruiting newly qualified doctors and actually training them to become GPs. And as I say, we also now have some additional new GPs coming in through the expanded R's programme. So we've taken that very seriously, not just as an ICB, but as a whole, as the NHS. We've taken that issue really seriously. The other thing that we've done in terms of improving primary care is actually about improving access and making it easier for people to access their GPs. And this has not been without its own degree of controversy, because, again, we're probably better at trying to sort the problems and resolve the issues than we are about telling people how we're actually going to do it. And we know that particularly in our older population, and Thurrock isn't unique with this, but particularly with our older population in Thurrock, we've had a number of complaints that have been raised. They're not quite so many now, but a few months ago we had quite a lot of complaints coming in where people really thought that they could only get a GP appointment by email when they don't actually have an email account. And it was causing a lot of distress. So we've addressed that, and the GP practices are continuing to address that. I don't think we've got it 100% right. That is reliant on each GP practice getting it 100% right. We don't always manage that, but I believe from the information I've been given that it's not nearly as dire as it felt to be some months ago. We're also doing some really proactive work around learning disability and serious mental illness around physical health checks, and we are continuing that work. We're not sitting back on these things. We did a raft of work around this a few months ago, starting last October, and we're actually taking that work forward. And in Thurrock, we're actually working with Thurrock Healthy Lifestyles, Thurrock Lifestyles, I get the name of the... Thank you, Thurrock Healthy Solutions, that's what it is, thank you. To support adults and children with learning disability, and actually we're going to be putting some additional capacity into the system alongside Thurrock Health Solutions to support more people with LD to actively engage with their GP practice and get their health checks. That hasn't started yet, we're still in the planning stage, but that's something that will happen and will be coming on stream during this financial year. And again, happy to bring something back as an update, if you wish, Councillor Hooper, to a future meeting, just so that we can make sure everyone knows where we are and how it's working. Now, here's where I get a little bit sketchy, because it's other colleagues that have really put the detail into Chapter 6 and Chapter 7. So, improved health and well-being through population health management. It was colleagues in public health that have actually provided me with this, and I take every word that they've said as being correct. So there is a framework for improving detection and management of long-term conditions. And I have to say that with hypertension, high blood pressure and cardiovascular disease, Thurrock is absolutely outstripping every other part of Mid and South Essex. We have by far the highest hypertension detection rate, and there are programmes already in place that are aimed at reducing the number of heart attacks and strokes over the next 5 years, because we are so good, so good at actually detecting hypertension much, much earlier. And there are programmes that are happening throughout primary care and across our community health providers with our public health colleagues helping to drive that, so that we can really gain momentum on that and we can really see a difference. It will take 5 years to see a reduction in heart attacks and strokes, but if we don't start the work now, more people will end up more poorly in the next 2 or 3 years. Smoking cessation. I hope Sharon won't mind if I just touch on some new arrangements that Sharon has put in place. The public health team under Sharon's leadership has actually taken smoking cessation out from primary care, because primary care don't do it very well. And primary care would tell you the same. They don't do it very well. But public health teams do. And I think the last piece of that jigsaw is due about September with the prescribing. So at the moment, our GPs are still prescribing the required medication when someone has been assessed and they wish to stop smoking. But by September, there will be a final piece of that jigsaw in place, and they won't then need to prescribe, and it will be under the leadership and the governance of public health. I think I got that right, did I?
Just quickly so some stop smoking medications can only be issued by prescription. And Margaret's absolutely right that historically in Thurrock, the burden of that has fallen to our very busy GPs. So the work we're doing at the moment with the local pharmaceutical committee and local community pharmacies is that through a patient group directive, pharmacies will be able to prescribe and issue that medication. Negotiations are still taking place, but we already have a number of community pharmacies in Thurrock who work with public health on substance misuse services, for example, and some other services. So we're hoping they will be in the first tranche of local community pharmacies that will get on board with this. The advantage of community pharmacies, you don't need an appointment. We're going to try and ensure we get a spread across Thurrock so that people will have easy access to this. It's all being funded out of the public health grant. So we're hoping that it will be really, really successful. We'll take work from GP practices to free them up to be able to do other things. So I'm hoping that we'll be able to do a press release either September, October, where we'll be able to share how many community pharmacies have signed up to the scheme by then. But I agree with Margaret, it's a really positive development.
Thank you, Sharon. If I can move on to Chapter 7, Integrated Care and Support in the Community. This really is, I've touched on a lot of this already in relation to PCNs and the integrated locality teams, and doing the multidisciplinary working and moving towards integration. And actually what we'd like to see over the next 12 months or so is more like blended roles and so on and so forth. There's a trusted assessor approach to this, and I was in a meeting last week where we had some senior housing department colleagues, senior housing department colleagues in that meeting, and what they are doing about training up their staff, not just in sheltered accommodation, but in general needs housing. And they will actually be very much part of those integrated locality teams. So an integrated locality team isn't just about health and social care, it's about everything. It's about anything you can think of. So economic regen, housing, police, ambulance, you know, whoever, whatever. CVS is in there, right in the thick of it actually, particularly with the By Your Side service, which is absolutely key to a lot of the delivery right across this borough. We've had an exceptionally successful early years oral health programme. It's in its second year now. It is due to finish in December, but that doesn't mean that people in Thurrock, children and their families, will be left high and dry come December, because our dental commissioner within the ICB has expanded that. He's looking at the whole of Mid and South Essex, but Thurrock is absolutely in there. And he has expanded that, and he's building on what that NHSE-funded programme did. The programme itself has been remarkable. And I think we did ask if we could come and give a full report on that at the September meeting. But it won't end in December. The work that started will not end in December. It may look very slightly different, but it will continue to support children and families in the borough around their oral health and their dental health. I won't go into too much detail about the Falls service development. I'd love to, but I don't have time, and I'm happy to come back, and I'd like to do a report on that in September and give you the full detail on that. I just did want to mention that there's a new carers intensive support service that's about to start. So the new Falls service, which is a strength and balance programme, and the new carers intensive support service in Thurrock for Thurrock are due to start. They should be in place by July. I'm not exactly certain what date in July, but it should be July. Again, a little bit more on the health side, integration of the urgent care response team, tissue viability and long-term condition management. They're being drawn into part of the integrated locality teams. And the whole point of the integrated locality teams is that they need to move as far as they can from reactive to proactive care, so that we can do the primary and secondary prevention to keep people better in health, improve well-being, at home for longer, more confident, more independent. At the moment, they're still principally reactive and doing a very good job on that basis, but we now need to help them move the majority of their work from that reactive phase to a proactive phase. And I dare not mention the CHIP programme, which I'm sure most people in this committee are aware of, but I'll get shot down by Kerry Armstrong if I don't mention the CHIP programme, which has done remarkably well for people with serious and enduring mental health who were very troubled and very challenged and very challenging to work with. I know I don't have time to cover chapter 8 and chapter 9, I'm afraid. If there's any specific questions around these chapters, I'm more than happy to take them, but I should probably stop there. I could talk for hours.
I know, Margaret. Thank you for that, Margaret. Are there any questions? Councillor Rigby.
Thank you, Chair. Thank you, Margaret. I'm just interested to know a bit more about the data collection, please. How you're going to do that and what areas you're going to focus on. The data collection that you're going to do to assess how it's working, really.
That, I think, is something that our public health colleagues have offered to help with. I don't have the working detail, but an offer was made in the last BCTT exec meeting by one of Sharon's members of staff. I'm not quite certain where we've got to with that, because we're not due to have the next meeting until next week, I think it is, or maybe the week after.
It's work in progress, Councillor Rigby. So like every health and care system, we have tons of data. We have loads and loads of data. What we haven't necessarily got is the story around that data, you know, the analysis of it and the kind of narrative that goes with it. So what we've been working on for a little while in the Public Health Intelligence team, working with the business intelligence team in the council as well, and our NHS colleagues, is how we can develop a systematic way of being able to collect, analyse and use all of the data that we've got. It's something that when the Care Quality Commission, the CQC, were here recently, in my interview with them, that was one of the areas that they raised with me as well. So we have identified it, as Margaret has said, as an area that we need to get better at. We're not perfect at it. It's work in progress. But yes, we're leading that piece of work as a public health intelligence team, but with other colleagues.
Councillor Worrell.
Thank you, Chair. At the beginning of your report, you spoke about that you feel that you probably haven't engaged with residents well enough and that there's more that could be done. And I think as a council, you know, we feel your pain because we have the same. And it doesn't matter how much you do, you never feel like you're doing enough. But I just wondered if what you feel you could be doing and how you're going to do that and how we could dovetail some of our engagement with the engagement that you need to be doing to make sure that there's a bit of a win-win, but also a bit of a joint working group there.
Thank you. Yeah, brilliant question. We should all be working on the same issues anyway together. And one of the things that we need to be doing much more of in the ICB is co-production. That's the first thing we need to be doing. It's something that's come late to the NHS in many ways. The NHS it's like trying to turn a tank around, trying to make any changes. And it can be a little bit slow to get to the point that local authorities get to a lot quicker, usually. And the style of commissioning in the NHS, commissioning of services, is quite different in some regards to the way local authorities have more freedoms and flexibilities around what they can commission and how they can do that. And I think that creates a little bit of, I think it's a permeable barrier, but I think creates a little bit of a barrier in terms of mindset and thinking sometimes. Not all the time. And those of us that work in alliance teams are much more with the programme, so to speak. I think sometimes when you go more central into the NHS, it becomes more challenging for them to really understand how co-production can actually really help them. And so that's the first thing. And I think one of the things that we try to do is to be as engaged as possible with council events and with CVS events that are happening. And, you know, we're engaged, we're in there, we're trying to contribute, we're trying to understand, we're trying to learn. And most importantly, we're listening. And I think that's the key thing, we are listening. And I say that for the whole of Mid and South Essex ICB, we are listening. And that's reflected in some of the conversations and the meetings we have internally as well. And I think that other parts of the NHS are also now listening. Our acute trusts, I think, are now much more engaged and much more listening to what their patients are telling them. And I think one of the things that's a bit telling is the words that are used to refer to people. So in acute trust, because they are patients, they are referred to as patients. We refer to our local people as residents of a particular area. Personally, I think we should just call them people, if I'm being honest. But that's my personal view. But we are actually helping other parts of the NHS get to that point of really actively listening to what local people are saying is a real problem. And then we need to work with them to resolve that, and that's where the co-production comes in.
I will be really, can I just ask a really quick one? Because you didn't get to part 8, which was the bit that I was really interested in, and it talks about delivery of blended roles in upskilling carers to undertake certain tasks undertaken by healthcare assistants. Now, something that I feel really strongly about this, because I just went through a year of having to deal with how hard that is to be a carer. So I just want to make sure that there's no extra burden on people that are carers, you know, and to take away services. So how will you safeguard to make sure that it's not just loaded onto that family any more than it already is because they're falling over? So it's not about, you know, passing care on to somebody that really shouldn't be caring any more than they already are caring, because we are caring out there.
Yeah, think that might be a slight typo, because when we say, when the word carer has been used, it should actually have been care staff. It's not family carers that we're talking about at all. This is something that our colleagues in Rob's directorate are working on. It's about upskilling and actually broadening out the remit and the role of paid care staff with proper training and proper competencies in place and proper supervision and support, so that they're actually, to be honest, one of the things that we need to do in general is create more of a career pathway for care staff, rather than some people seeing it just as it's just a job. And that's one of the ways we can do it, is to actually upskill and train and broaden out the training and give them and empower them to actually do a wider role.
Okay, so I think that maybe that's something we need to come back to, Councillor Worrell, and maybe we'll put that on an agenda for future meetings. Yeah. And I think in terms of that joint working, maybe if Rob and yourself get together and look at what community events we're doing, and so you can be part of those events. If it's okay, if I can move to the recommendations. The recommendation is the board members note the content of the report. Is it noted? Thank you. Okay. If it's okay with the committee of the board, I will move on to item 7. So as you can see that the Better Care Together and our health and wellbeing strategy end at the same time in 2026. So we're looking at an approach to refresh the health and wellbeing strategy and Better Care Together Thurrock, the case of further change. And I'll just ask, the covering report's on page 30. I'll ask Rob if he'd give a presentation on this, please.
Thank you, Chair. So when I walked in here an hour and a half ago, this is a very simple paper. When I walked in an hour and a half ago, I had a really simple introduction to it. If you could look inside my brain now, it's like a little atom field. There's bombing all over the place because I've got so many things I want to try and get out in this very brief introduction. So Margaret has done a sterling job in explaining Better Care Together, Thurrock, and the case for change, and the content and the actions that we take on that. So I'll just try and put a bit of context and then bring the health and wellbeing strategy into it. So 2022, both documents were published, and they time out, as the chair said, next summer. It was quite appropriate for those two documents to be published separately, prepared and published separately at the time, because we were at a different place in our maturity. We were less mature than we are now. Broadly, Better Care Together Thurrock is kind of the operationalisation, the delivery, and the actual impact on local people. Yeah, and so it wasn't in place at the time, to the extent it is now. And now you can see on a day-to-day basis, if you're out in the communities, you can see the integrated teams. You can see the well-being teams, how they work with communities to try and upstream interventions around mental health and emotional well-being, to try and catch any issues and give them support at an early stage. You look at local area coordination and how they can work with people and capture them to provide, signpost them to services in the community, to products which may help them, telecare, etc. So there's a lot of operationalisation which has been driven by Better Care Together Thurrock, as Margaret has just explained. The strategy 4 years ago, 3.5 years ago, was that kind of broader vision. It's articulated quite simply, but I mean, the way I'm trying to describe it, and everyone I speak to, including my teams, is, it's about better health and care outcomes. It's about closer to home. And it's about being realistic about the resources we have available, and we've got to operate within those resources. Now, funnily enough, that marries really, really well with the current direction of the government. If you look at what they call left shift, which is about the NHS wanting to move more from acute to prevention, more from acute to community, taking a stronger preventive approach and looking at the greater role of digital and technology-enabled care. In that space, when we did the strategy 3.5 years ago, it had the 6 themes. I won't run through those themes, they're in the paper, and it may be they're completely appropriate. Now, what we are proposing is, without going into the detail here, we'd like permission from the board to go away and look at, because we've got a more mature system now, relationships are better, delivery is more integrated. I think we're now in a position whereby, if you look to those two strategies, they have a huge amount of overlap in their high-level statements and priorities. We're in a position now whereby we would like to suggest that, with the timing out in a year's time, we look to refresh those two into a single document, which is more high-level statement as to what we want to achieve for the next 3-4 years, take us over the hill of local government reorganisation, because whatever that looks like, our communities are still going to be here, still having demand on our services, and still needing to be supported. We do want to do it in a co-produced way, so if I can go back to the leader's question a minute ago. When I came, I think the first 2 weeks I was here, we had an integrated locality event up in Corringham. We had another one, which I was hoping was going to be broader to the general public, the week that the inspectors for CQC assessment team were on site. We didn't make that more broadly open to the public at that stage for a variety of reasons, but the intention, and I've been speaking with our comms team, and comms are engaged with NHS colleagues in comms. The intention is that later this year we're going to move those into 4 locality-based forums, so we can take them out into the different areas of Thurrock, and that could be one of the vehicles, just one of the vehicles we use for the co-production of an aligned strategy. And it may be, and I'll just throw this out just to give you food for thought, we have a health wellbeing strategy at the moment under the 16s. It may be that the community say they're absolutely right. They're the 16s we want to stick with. We don't want to shift it. We just want to update it. It may be the conversations we'll have. They say, well, actually, some of the places, and you've mentioned it today, so I will mention it, there are some places which have a health wellbeing strategy under the four wells. So starting well, living well, aging well, and dying well. And I would argue, take all the comments earlier today about dying well. Yep, absolutely. But for me, it sits at a strategic level first, because you've got to have that high-level conversation. You've got to kind of make people feel comfortable with what the conversation is about. It's about preparing for good death. It might be starting work in, I didn't work pretty well. You start working in your 50s. It's not about kind of end of life. End of life is the worst time to be doing these kind of things, because you're at crisis at that point. You want to do it before you're at crisis. So it's about kind of making people feel comfortable to have those conversations. So this is fundamentally saying, because of the maturity of the system we have in Thurrock, because of the relationships we have, not just between the NHS and the council, but also with the CVS, with providers, with broader communities, to use this as a mechanism and say, what's the next stage? Let's try and stay ahead of the curve. I think you've been ahead of the curve. I'll still say you, because I've not been here long enough to be able to take any ownership of it. I'm very proud to be working in the system now, but I think this is an opportunity for us to stay ahead of the game and really do something quite innovative to give us that strategic overarching vision for what we want to deliver for the next 3-4 years, under which you'll then have operationalised plans which will continue to come to the Health and Wellbeing Board for kind of reporting and accountability. One thing Margaret did mention, just to explain it here, is we have TICA and we have BCTT Executive. TICA is Thurrock Integrated Care Alliance, and then the Better Care Together Executive looks at, so TICA should be making that more strategic. So that's going to be the group which kind of takes that vision in the health wellbeing strategy and says, how do we want to deliver this vision? What's the nuts and bolts? Which are the key partners we need to drive this? Improved housing, what that means about for health wellbeing in the communities. The key health issues we know around COPD, cancer referrals, long-term conditions, the ageing demographic that we have. The working age population is going to come in with the new population that comes here, and the health issues, trying to get more of a life course system. So prevention sits with your children. I talked a lot to Sheila Murphy about, we're absolutely on the same page, that prevention, our children and young people are our key preventive agenda, because get the principles correct with them, and we've got a really good chance of going for better outcomes further down the life course. So I think so we're looking at that TICA being that strategic, and then Better Care Together Executive takes the operational the operationalisation that we just discussed in the we've got one strategy and says, right, this is how we're going to deliver it, this is how we're going to measure it, and actually let's look at it probably from a simplified approach. On my, another question about performance going forward, I would like to suggest that we try and identify a simpler dashboard which really looks at what the impact is on the local population. So, are people happier with their health? Are long-term conditions being better managed? Are cancer referrals through to treatment at times shortening? Are waiting lists shortening? Are the weight management piece of work which was undertaken here recently, how's that impacting? So this is an opportunity for us to go out to the community, talk to them about what their priorities are, building on what Kim said about the NHS work that Healthwatch led on around the 10-year vision, which is coming to TICA next Thursday, Therapeutic Integrated Care Alliance next Thursday, to agree the next steps in that journey and taking that back out to the community. So hopefully that's a little introduction to what this paper is about, what we're seeking permission for here. And the one thing I would also just mention in the third recommendation, I'm sorry, I've been a bit repetitive, but I wanted to stress the VCSE compact, or charter, sorry, because I want to make sure that in everything that the Directorate does, and I would suggest the Council does moving forward, we absolutely place co-production at the heart of what we do and the role the VCSE could take in helping to support us in delivering that in the future. Thank you, Chair.
Thank you. Any questions? I actually think it makes, sorry.
Thank you. Just going back to a lot of discussion on community engagements, how are you going to ensure that you get a broad enough base, a range of people? That's really the thing. So you get a big pool to get your answers from.
There's no simple answer to that. It's always a challenge. I mean, I have a history of you go to the community and we end up talking to the same 5-10 voices everywhere you go to. Those voices are really valid, so it's always important to keep them in the room. But I think I would talk. We will talk. We've got a very good network already, and we've talked to the people. We've got good relationships. So, I won't over-egg this one because it wasn't us. I give credit to Healthwatch and CVS, but the NHS piece of work we did earlier this year, that was a national piece of work to get responses back on the NHS plan through the portal. We were given credit by central government for the depth and the breadth of our response. We got over 530 individual responses, I think, and a range of organisational responses. So that shows that we've got networks out there that we can engage into. We've got infrastructure, we've got libraries which we can make much better, which we can make use of. We've got community organisations, we've got local area coordinators, we've got 20 local area coordinators placed across the borough. So we've got really good links into the community. We've got councillors who know your constituents better than anybody else. So we use all those mechanisms and we bring them together and we just make sure that we keep everybody communicating. So that if I miss somebody, then you won't. We make sure that we give an opportunity for everyone to feel their voices heard. Final bit is to make sure that people feel trusted and they feel heard. Because if they feel heard, and even if you don't act on, even if you don't deliver what they wanted, as long as they know they've been considered and you can explain to them why you didn't do what they wanted, they're more prepared to accept that. But more importantly, on many occasions, we'll actually try and deliver what they want because that's the best thing for people's outcomes. So it'll be a matrix of approaches.
James.
Thank you. Yeah, I chair the Thurrock Safeguarding Adult Board, and we too are about to embark on our consultative process because our 3-year strategy runs out this year too. And the risk is that we might end up asking the same group of people separately, broadly similar questions. We're coming from a slightly different angle, of course, but that's the risk. And I would like very much to work very closely with colleagues who are engaging in this consultative process to see if there's some common ground to minimise that, streamline it, and working with our police and health colleagues too.
That's a very good point. Thank you, James. Mark?
Yeah, I'd just echo that. I think there's a lot of engagement that's happening. I think the issue is how we're kind of like listening and kind of joining up those conversations. And the risk is that those conversations happen in silos. So we talk to the public around arts or physical activity or safeguarding, and actually the themes will be broadly similar. So I think there's an opportunity here just for us to take a step back and really think about how we coordinate the engagement that we're already doing, because there's a lot that's happening at the moment. But I think there's a conversation to have about how we kind of join up and listen and kind of join up the themes from the conversations that are happening, because people get a little bit sick of being consulted and not actually feeling like there's a sort of tangible result. But there's so much engagement happening. I think it's in how we listen, in how we learning, how we kind of coordinating.
So can I just, I think you're absolutely right, Mark, and Jim's point is well made as well. So part of me wonders whether sometimes we try and overcomplicate this and over-intellectualize it sometimes. So you go down kind of one area and you feel you've got to really go quite deep into that to justify that. Whereas actually there's a general set, if you go broad, the messages, the key outcomes, what people want to achieve are broadly the same. So I think it's possibly something, I've always felt it's easier to give someone something to comment upon rather than just ask them what they want. And so, you know, if we did some work taking that broader, not siloed approach, but kind of that broader agenda across the environment, across place, across health, across economy, across social care, that broader perspective, and say these are the 10 principles that we really want to drive forward, and not expect us to go into the detail down every particular person's or organisation's interest, then people might then coalesce around that, and we can then get a more unified picture. So I think it's a really good point. I was involved in something 20 years ago in a previous local authority, which was, it ended up being a TV programme called Making This Place Happy. And it came up with a couple of principles which didn't just tick the health box or the social care box or the environment box, but it said, pick up a phone to a friend who you've not spoken to once a month. Say hello to someone that you don't normally say hello to. It was just little things like that about making that place a happier place to be. And it just touched on a whole range of agendas, you know, community safety, etc. So I think the point is well made. I think it's probably for us to potentially drive some options or prepare some options that we can take out to communities. Then communities can say, you're way off base on that one, or no, you're good on this, and just go with it. Does that help?
Okay, any other questions? Right, I think it'd be wise to bring the strategies together. I think it'd make it easier to follow. Trying to follow two different strategies seems to be a bit complicated. In some ways, both strategies can argue with themselves. They're not quite saying the same things. So I think having one overall strategy is actually a really good move. Okay, if it's okay with members, I will go to the recommendations. Right. Agree to the proposal to prepare an aligned and refreshed strategy to prepare let's start again. Agree to the proposal and prepare an aligned and refreshed strategy for the period of 26 to 29 to replace both the current health and wellbeing strategy and Better Care Together Thurrock upon their expiry in summer 26. Agreed? Right. So that means we require to establish a project group to lead on the preparation and this refreshed strategy, which includes representatives from council, local health bodies, the third sector. The board will expect the new refreshed strategy to be produced in accordance to the understanding principles of co-production, seeking involvement and engagement with those with lived experiences and representative organisations and stakeholders. Agreed? Right. Okay. I'm aware of time. Would we be wise to go to the board development day? Yes, and if I can defer the membership. Sorry? Okay. Okay, I mean, in terms of the board membership, I'll cover it very quickly then, because I do want to broaden out the board membership if it's agreeable. One, I'd like to get someone from the Free Ports as part of this board. The reason I'm suggesting that is because I want their involvement in actually supporting us to help get our long-term sick, and we have one of the highest long-term sicks in the country, into work. And they will help in terms of prepare and train people back. They will help us prepare and train people back into work. Also, I think there is a number of issues around the environment and air quality, particularly as we're bringing new industries to the area. We're also building a new road and lots of new housing. So I think that's something we probably need to involve the Freeport in. And I'd also like to use their expertise and see if they can help bring some funding or experience into supporting our future healthcare professionals by funding maybe some training or sponsorship, people who are doing become doctors or becoming physios or speech and language therapists. So I'm quite keen to involve them. Do you agree in principle that would be a good idea? Yeah. I'd also just like to consider maybe on some items, maybe having someone from the youth cabinet come along and be involved in some of these meetings, because I think preparing young people for the future, our future politicians, would be a really great way to involve people and get their views on health and well-being within Thurrock. Okay, so yes.
Sorry, I was just going to say, just bear in mind, obviously it's school time, so youngsters will be in school at this point. So, but possibly at the end, they might be able to come towards the end.
Sharon.
Can we just like to suggest then that we bring updated terms of reference to the September meeting, so that they can be signed off at that time, so we can put it on the forward plan for September board.
I agree. Thank you. That's been agreed. Can I just move on to the board development day? So Sharon?
I'm happy to introduce this item, but it's for us as a board, really. So there's been a proposal that certainly in the time that I've been in Thurrock, we haven't had any board development sessions. So the purpose of a board development session is for board members to meet outside of a formal setting, so not a formal board meeting. In other local authorities where I've participated in these sessions, we've usually had someone facilitate them. Often someone from the LGA will come and facilitate the sessions, and it kind of helps. I mean, I'm sure Rob will want to say something here as well, but outside of a formal meeting, it gives board members a chance to get to know each other better. But it also allows the board to think about forward planning. So we've already had a number of discussions today about reviewing our JSNA process. We've had discussions about data intelligence. We've had conversations about the new health and wellbeing strategy. We know there's a lot of change in the system with devolution, the establishment of a mayoral authority, local government reorganisation within the ICB as well. And in formal board meetings, we don't really have the time to be able to have discussions about those issues that are affecting us as a system, how they might impact on our services, our staff, our residents. So it's a proposal really for the board to think about whether you would like to organise a development session, maybe some thoughts around when you might think would be a good, the right time for organising such a session, so we can go away and start planning it. So that's a starter potential.
I just think it's a good space to bring people together, which is in the public domain, where people can be really kind of honest about their particular positions, be it if you're in health or hospital trust, in community services or voluntary sector. So it will help us plan better. Just think giving that space would be really valuable. So in principle, do you agree? Right, so maybe we could look at some dates a bit further down the line. What are we thinking of?
I was thinking maybe after school holidays, but before we get way into the winter terms. So maybe September, look for a date at some point in September. I wouldn't suggest we go any later than early October, because if we want to use the session as an opportunity for kind of thinking about scenario planning for the future, we wouldn't want to delay it much longer than that.
Fair enough, and I'm really looking for someone from the LGA to help facilitate this day. Okay. Right, so that's agreed then in principle. Okay. Right, I think at that point, unless there's any other business, no? Oh, sorry, Rob.
Sorry, just occurs to me I should just mention under any other business that the board was cited on the fact that Adult Social Care had a Care Quality Commission inspection or assessment. Just so you know, that inspection is still live. So they were on site in mid-May. The inspection is live until the report is received. We do not have a timeline for that report at the moment, but we anticipate I'd anticipate somewhere probably the back end of July, just to keep you in the loop on it. I did have some informal feedback from Care Quality Commission, which I did want to share with the board, which is that whilst they are very, very careful in the language they use, they recognise a number of key strengths in Thurrock. Particularly, they mentioned that they were satisfied, they were not seeking any further information around our approach to integrated working and our relationships with providers and partners. So I would like to thank all colleagues, both within the council, but especially those external bodies and organisations, for participating and engaging so honestly and thoughtfully with the assessment team when they're on site. As soon as we have anything that we can share in the public domain, we will let you know. But as I say, don't hold your breath. They're taking some time to get through the process of preparing the reports and then consulting with us. Thank you.
Thank you, Rob. Councillor Rigby.
Thank you, Chair. I just want to check with Sharon that the women's health strategy is on the forward plan, please.
Helpful reminder, thank you, Councillor Rigby. So something we haven't discussed on the agenda today, but it is something that we've discussed previously as a board, is about having a forward plan in our papers, so that we're able to look at forward agenda items. The forward plan, I'm looking to Ben here to correct me if I'm wrong, but the forward plan at the moment, the last time I looked at it, it's very light. There isn't a great deal on it. We've identified a number of agenda items for the September meeting today, so it sounds as though September will be quite a full agenda. But we do need to think about the priorities that the board wants to be looking at going forwards, that we have a populated plan. I mean, one of the proposals that's come forward, for example, is a women's health strategy. That is something that would need to go onto the forward plan. There may be other subjects or priorities that people would want to see on that forward plan. I think that possibly we need to get better, Rob, at briefing the board on some of the work that happens in Thurrock Integrated Care Alliance, for example. So a request really from board members that you think about agenda items that you would like to see on the forward plan, so we can populate it. There's little point us meeting for 2 hours every 2 months unless we're going to use that time really wisely. So, and I think it needs to be an equal and shared responsibility for every board member to be putting items forward for the agenda. So please use myself or Ben Russell as your contact point for that. We hold the forward plan in public health, but obviously we can't populate it ourselves. We need all of you to be contributing agenda items. Thank you.
It's something I've raised today, actually, and I think it'd be good to bring a full plan to September's meeting. So, and I do think we need to be a bit focused, though, on what we're going to be doing so we can actually really work on getting some positive outcomes. There's a lot to do this year in terms of developing the new strategy, but I'll leave it there. But we'll bring something to the next meeting. And I haven't forgotten. Okay, with that, unless there's anything else, I will call the meeting to a close.